Dr. Marjan Seywerd. She's from Maine. Well, that's where she practices, I should say. She's from all over the world. I had the pleasure of meeting her when we had classes at the Institute of Nutritional Dentistry, not only on the East Coast but the West Coast. We were so impressed with what she knew that we started asking her to add lectures to our program. So without further ado, she's going to talk to us about mercury removal protocols. Thank you.
Thanks. It's very kind of you. Got your water? That's mine. Okay. Good afternoon. Basically, what I want to try to do for you is leave you with the impression that this whole protocol is not as overwhelming as it's going to appear as I'm going through it. A lot of you are very new to the whole business of mercury removal, and it is totally overwhelming. I've been through it, and everybody in this room who does mercury removal has been through it. The first thing that we do in my office is we go through a whole bit of a series of things. The first appointment is the exam, history, and documentation. Then we have another visit for health status, additional testing, and at that point we go through treatment plan, informed consent, and then we get down to business. And this is all necessary for a safe protocol. So the exam history and documentation is basically done by my support staff. We have the initial information gathering session. We have diagnostic x-rays within a year, and that includes the panoramic, bite wings, periapicals if necessary. We try to get a full medical history and supporting documentation prior to the patient's arrival. We document everything that we find, you know, all the pathology associated with the teeth, whether there are cracks associated with the mercury fillings, marginations, recurrent decay, amalgam tattoos adjacent or remote from the actual fillings. We also give them a copy of the Dentistry Without Mercury, which is put out by the IABDM, and it's just basically, we want the patient to come back with some questions. It is required reading. The book has been shortened up with the new 2014 edition, but we do ask them to read it. In the next session, when they come back for their consult appointment, this is done with myself and my assistant. And in this appointment, we check the health status and arrange for additional testing. We try to classify the patients as being a class 1. Class 1 patients are very healthy. They don't have a high risk factor. They don't have any complaints as far as mercury toxicity. They just want to get it out. And so these patients are put down as they want to have white teeth. Class 2 patients have mild health problems, and with these patients, we do proceed with a little more caution. We try to aim for biological support and all protections. Class 3 patients, these are the acute or chronically ill patient. We do refer these to their licensed healthcare provider for prior treatment. We do not treat these patients without clearance. If we get a patient coming in on renal dialysis, we don't touch them. They have to have total medical clearance. All the excretory organs have to be functioning in order to get some successful results. So on this consultation appointment, what we do is, I've already mentioned the separate appointment. We check for electrogalvanism. I'll come to explaining all of these things. We do biocompatibility testing, metal sensitivity or ELISA testing, which is for true metal allergies. The ELISA test is the only test which will test for allergy to titanium. And then we've got metal toxicity testing. All this stuff is referred out to the licensed healthcare practitioner. And then we have a question and answer session with the patient. We basically go over everything that we'll be doing in the procedure. At this point, I let my assistant take over, and she shows the patient the equipment, exactly what's going to be done. So they have a test run before they ever do anything. And I find it just makes the actual treatment portion go so much more quickly. So it's certainly worth the half an hour time that we spend there. Electrogalvanism. Voltage is the amount of potential energy that electrons have relative to another point. Like height, how fast would water fall from the top to the bottom? So it's a measure of the force. So voltage is force. The amperage measures the current of the flow, like a river. So you've got a big river, which is really wide and it has lots of water per second, or a little one, which less water. It is a measure of the amount of electrons moving in a circuit, or how fast. The electrical current reading gives a general idea of the speed of electrochemical reactions, which occur on the surface of a filling. Dissimilar metals in teeth in the presence of saliva, such as mercury, gold and adjacent to mercury, stainless steel, cause galvanic action, electrical currents, and higher mercury vapor levels in the oral tissues. A gold alloy bridge over mercury, which is totally contraindicated in the MSDS sheets, however it is done, will leach 30 micrograms per day, which over a period of 10 years is 101 milligrams. The gingiva adjacent to mercury fillings have been shown to have levels of 200 parts per million. At the root tips, inside the bone, they're finding 41 parts per million. The electrogalvanism enhances the release of other metals as well. So, and these are heavy metals, so you get silver, tin, copper, and zinc through these currents. These are all certainly the copper and the zinc, all parts of enzymatic reactions which occur in the body. The mercury accumulates in fibroblasts, macrophages, and multinuclear giant cells of the connective tissue, the blood vessels, the nerve sheets, and the basement membranes of mucosal epithelium. It's dispersed to the gums, the base of the teeth, causing local health effects, and systemic lesions. This is where you get your leukoplakic lesions coming adjacent to the mercury fillings. Once you remove those mercury fillings, in a great number of cases, those leukoplakic lesions actually disappear. Currents over 5 microamps can cause significant health problems, such as headaches, migraines, dizziness, and nausea. Electropotential differences of over 50 micrograms, 50 microvolts, are associated with leukoplakia, lichen planus, or toxic and allergic reactions to restorations. These electrogalvanic potentials can range from minus 417 microvolts to plus 150 millivolts. Negative potentials may be more pathological than the positive. Patients with autoimmune conditions like MS generally have a greater number of electronegative fillings. The electrical current gives a general idea of the speed of the electrochemical reaction occurring on the surface of the filling. The brain operates on 7 to 9 microamps, which is 1,000 times weaker than the currents resulting from non-precious metals in the oral cavity. This may interfere with the energy flow to the brain, with a negative impact on the autonomic system, on the energy meridians flowing through the mouth and maybe be a factor for the energetic imbalances of different energy areas of the body. Healthy gold crowns or composite restorations most often register a positive charge. A negative charge greater than -2 indicates decay under an old filling or the presence of mercury amalgam under a crown. Highly electrical restorations cause surrounding teeth to have higher readings. Electrogalvanism reflects conditions that encourage the conversion of ordinary toxic mercury into methylmercury. The higher the amperage in the negative electrical mode, the more conducive the environment is to conversion into methylmercury. Positive charges do not indicate safety. They just indicate that toxins are being released at a slower rate. Sorry, I've developed a horrible cough. The electrogalvanic devices measure the microamps, which determine the ions leaving a restoration. Every microamp equals 3 × 10⁻12 power ions which leave. The readometer is used to measure electrical charges. Normal readings on teeth are +2 to -2. Caries susceptibility is related to the migration of calcium from the enamel with the metallic ions from the amalgam. Dental amalgam is electronegative. Here's a picture of a readometer. And basically what we have a ground which rests in the floor of the mouth. And then this is measures the current. And then the readout comes right here. And we'll get readings with variable positive and negatives. That's the ground in the autoclave bag, and the pointer is right there. Another device is the oral potentiometer. It does the same thing. You've got your ground right there, the black, and then the handle which has the move on button there for taking the readings. So the Pertec oral potentiometer runs $2,000. So today you're going to get ballpark prices. I have updated them as much as I could. So you will have an idea of what it costs to set up for mercury removal equipment. The readometer, went far, is put out by Matrix Incorporated. They are getting difficult to get, and because of issues with getting parts, you may not be able to get them much longer. Yes?
I'd just like to add that if you go to Radio Shack and get a home meter, it does the exact same thing. About $35.
It just doesn't look as pretty.
Doesn't look as pretty, but the results are just as good.
Yep, agreed. Okay, so you saved yourself a fortune right there. Thanks, Mike. Hey, you got it. That's right. Only you. The serum biocompatibility testing, Michael's already spoken of. It tests, and this is for biocompatibility to dental materials. So the blood serum is tested for pre-existing antibodies to the metals and chemicals found in dental materials. Each chemical is graded, whether it creates clumps in the serum, indicating an antibody to it. The results are cross-referenced with a large database of dental and medical trade name products. So we've got Clifford Consulting does a test. The charge for that is $295, which we bill. We just have the patient send it out. We do carry the testing, and we do not charge a fee for reading it. The biocomp labs are $275. The difference primarily between the two, and I'm sure there are many more, but is the way they handle aluminum. A lot of your ceramics have aluminum materials in them, and generally speaking, biocomp labs has the aluminum as all being bad. Clifford breaks it down into insoluble aluminum, so he has more satisfactory readings on the ceramics. The ELISA test is developed by Verishtejko, and it's the only scientifically validated test which measures the metal allergy. In vitro lymphocytic test for delayed hypersensitivity to the various metals. What happens is the cells are exposed to the metals, and you get a sensitive reading. The lymphocytes grow large. In a non-sensitive individual, the lymphocytes do not show changes. Oh, it's doing things that I don't know. It's magical. So metal toxicity testing, you've got your DMSA provocation. Here we go to the licensed healthcare provider. Doctors' data will do a pre and post DMSA provocation to get the urine levels of mercury and other heavy metals. Then we've got quicksilver, and that's Chris Shade's test, and it's a tri-test with blood, urine, and hair. Urinary porphyrin test. This is performed by Metametrics Lab. Mercury is the only heavy metal that causes a blockage in the conversion of porphyrins in the hemoglobin and the energy stores unit of ATP. It robs the body of energy needed for repair and the normal activity. The blockage of the conversion causes the porphyrins to accumulate in the blood until they spill over into the urine. High levels indicate that mercury is causing a problem. The next section is treatment planning. What we do in our office, based on the read-a-meter evaluation, we organize the treatment plan into quadrants, as long as the patient is not extremely heavily sick. And what we do is remove the most electronegative quadrant first, and then we progressively go. So with our little chart, with the read-a-meter, we have the most negative, second negative, third negative, fourth negative. So given that, what they found are you get the best results, and the patients are not pushed into a dumping. If you take out an electropositive quadrant, you'll get a dumping of electrons, and the patients can become symptomatic. If you have a really, really sick patient, such as with leukemia or ALS, there's something called an absolute sequence, and this is when you can have a filling on one side reading -12 here, -6 here. You take them out according to sequence. So you might only take out one filling during that one particular session. And it's just, okay, and here, oops, sorry. There we go. So there, -12, -9, -2. And then we go, once all the negatives are out, then we go to +20, the most electropositive, the thing that will give the biggest dump, down to the +10 to the +3. Yes? They can. So we do it as a relative. It's about the best that we can do. If they've been chewing on all kinds of stuff, they're definitely going to change. And if we were to, what happens with a read-a-meter, if you try to get the same readings on the same day, those charges will be discharged. So you do have to accept the first readings that you get. From the teeth. It's the galvanic cell that's set up. So what we're doing is actually putting the probe right on the teeth themselves. They don't always. If you have a gold crown, you can find it'll be negative or positive. The longer you do it, the more varied your readings are going to be. And, you know, sometimes I'll expect to get a certain reading, and then it just blows my mind with what I'm actually getting for a reading. And the tooth, because you think at a certain point you've done so many, you know which are going to give you an issue, and then it's like, oh my God, that is not the tooth that I thought was going to be the prime cause of problem. So it does change, okay? And I think some of the other factors that are included there are the amount of margination that you've got in there, because sometimes you'll get a deeper cell set up at the base of the filling. And then you've also got other factors like DiCal, and DiCal will give some really nasty readings. Okay. What we also do is remove every filling or quadrant removal session is a different day of the week. We never, ever, ever repeat the same day. And what that's based on is the 7, 14, 21-day immune challenge. So basically what happens if you were to remove fillings on day 1, you've given your body system an immune challenge. If you do another quadrant on day 7, which say it was Monday, then it would be Monday again, your immune system has a memory. So all of a sudden, you've given it a challenge on that same sequencing. So your body does react. And it's going to react regardless, but we try to fool it so that the next time we do it on a Tuesday or a Wednesday or a Thursday. So, and sometimes we have to come in extra days and work just because we're trying to be kind to the immune system. But say that the person had day 1, day 7 he went and got a needle for something else. He could have symptoms stemming from the first immune exposure. So, or have a trauma. He will get symptoms. What we do also is limit the appointment length to 2 hours. We don't sedate patients in our practice. I tend to shy away from it. Maine has gotten pretty restrictive with their sedation regulations. And what we try to do is complete the treatment within 4 weeks if possible. We found that starting a patient off on some biological support 1 to 2 weeks before amalgam removal seems to condition the body to excrete the unwanted mercury and to begin tissue repair. The excretion of methylmercury and inorganic mercury tends to increase if the supplementation is started prior to the amalgam removal. We ask the patients not to take any oral vitamin C before mercury removal. It does interfere with the duration and the potency of the anesthetic. We do give them buffered vitamin C or lipospheric vitamin C directly after we've finished our procedure, when we no longer need anesthesia. For biological support, we recommend a high-quality multivitamin complex, a multimineral complex, which improves the efficiency of the cell membranes. We like to have digestive enzymes just for inflammation. Chlorella, we highly recommend it because it helps carry out the heavy metals. Absolutely no cilantro prior to any mercury removal. And this is because of its mobilization effect on the mercury itself. We do recommend vitamin C except for 24 hours prior to the revision. And then there's a few others. But what we find is for most patients, the more things you ask them to take, the less they're going to take. So you get about 87% compliance for 1 pill. By the time you hit 4 pills, you're down to 22% compliance. So I've learned over time, rather than having a list of 30 supplements, keep it as small as possible. Yes. It is absolutely a heavy metal chelator, but it is also a mercury mobilizer. So as long as you have mercury in the teeth, it passes the blood-brain barrier. It can get from the teeth into the into the brain. Okay, so what we want is just a chelator, like chlorella, keep clear of the cilantro until all the mercury's out of there. And by all means then, once the mercury's out, really get the cilantro going. Because you want to get as less running around. You're going to get mercury release in the body regardless of all the precautions that you take. It's just one of those things because we're not perfect in this world. Yes, ma'am. So no mercury until all the cilantro is out. Whoops. Must have been the last mercury removal. Okay, no cilantro until the mercury's all out. Thanks, Mike. That was good. For nutritional support, do recommend high sulfur compounds, such as eggs, garlic, broccoli, cabbage, and then things like with good fats in them, sesame seeds, butter, good meats, organic if possible, veal, lamb, avocado. Those are all wonderful things. The wheat germ oil, sunflower seeds, and vitamin E. The fats are good things to have. And that's just a repeat there. I did forget to take that off that slide. Okay, then we're on informed consent. And the nice part is, I don't have to add anything to this because Michael did it all. So that one is done. Now we're at the nitty-gritty. Basically, we've discussed the biological support. Then we go through preparing the patient. We use an activated charcoal slurry rinse prior to doing anything with the patients once they've had anesthesia. Then we cover them with protective drapes and use HGX cream. I'll explain all this as we're going through because this is the nitty-gritty. We use an alternate air supply with a nasal hood, absolutely no prongs. We have eye protection. We use a non-latex dam, and in situations where we can't reach the tooth, we'll use the cleanups. We use a high-volume suction saliva ejector and a low-volume underneath the dam. We try to cut out the amalgams in chunks as opposed to pulverizing it. And then we use a 45-second rinse for slurry removal, just with plain water. And then we have a medicated rinse that we use post-op as well. So for patient protection, we've always got to deal with eye protection. We need a dental dam, plus-minus dry aids, cleanups, have a fan, and a negative ion generator. This is absolutely bare bones protection, and with what we know now, that's really totally inadequate. For a patient with class 2, these are symptomatic. We give them, you need the standard protection plus nutritional support, reduction of their bioburden, which you're doing with some of this nutritional support. You need oxygen or fresh air. We just use medical air, which is the same as scuba diving air. There have been some studies that showed that oxygen, pure oxygen, will enhance mercury absorption. We use a dental air vac, patient drapes, which are discarded after the mercury removal, and then recommend a sauna or a detox bath with Epsom salts after they've had treatment. Acute or chronically ill patients, refer them to the licensed health practitioner. They need clearance. Their excretory organs need to be functional. They need to have a negative ion generator during the procedure if it does turn out that you're going to do something. We need filtration devices for the office space, and all the described procedures are necessary. With a pregnant and lactating patient, I only do emergency removals, absolute emergencies. With pregnant, obviously, if they've got a toothache, you've got to do something. And hopefully it's only during the last trimester. The fetal tissues are particularly vulnerable to the mercury insult. And with lactation, mercury is going to be excreted in the tissues for 3 months after you've done removal. You're going to have differing levels. So I basically, if they're lactating, they want to have mercury removal done, I say you wait until you've stopped nursing your child, because I will not do it. Because otherwise you're mainlining it. And I won't have that on my conscience. I had 4 kids going through dental school and whatnot, and I've gone through the whole business, and I just don't want to contribute to someone else having issues because of mercury exposure. The prime example was I had a set of twins in 3rd year dental school, and I very wisely had all my amalgams removed in the 2nd trimester and replaced with amalgam. God bless my children. They're mostly okay. Okay, the basic armamentarium that we use. Okay, we've got a bonnet available from Shine. We rubber dam clamp holder, dental dam hole puncher. This is a clean-up put out by IABDM, non-latex dam clamp. We use a nitrous mask. And this is the charcoal, which we just mix up in a little cup, and the patient swishes it and swallows it. We do use color therapy glasses, and then we've got a full drape. Information, if you need to order this stuff, it's all there. So it's just provided as source material there. We do have the patient spread HGX cream. This is a sodium thiosulfate cream, and what it does, it helps prevent absorption. So we have the patient put it on the face where the dam is not going to be covering it. We put it on the outside of the dam, and it's very helpful to put it on our hands. Yes, we put it underneath our gloves in exposed areas. We do try to cover up, and there's a lot of, I'll come to that later. I don't want to confuse you too much, because you'll find at the end of this lecture that things are really minimal, because we're not perfect in this world, and there's still a lot of research going on for perfect protection as far as where mercury is landing in the procedure. So there's one of my patients with her activated rinse. She's got her glasses on and carrying on there. There she's got her mask. Dam is on, and she's got the hood, separate air supply. Okay, and then what we have a high volume suction on a dental unit. We have the Dental IQ Air, and it has 4 canisters with special filters for the mercury vapor. Faust Company does put one out. They're a bit of an albatross. Sorry. But that way, that can all be placed. We put a bonnet over the end there so it doesn't suck up gauzes or anything else because the suction is quite high. This is the unit put out by Faust. It's about $1,000 cheaper than the IQ Air. We have a negative ion generator put out by the Tact Company. And this is the generator here, and that's the collector plate on the wall. And it has little metal prongs, and those little screens come out at the front, and we just clean them up with alcohol gauze, and you'll actually see quite a deposit of the mercury on there. This is my alternate air supply. I did design this one myself, and it's just basically a tank, and I had my gas company build me the cart, and then here we have actually separate air supply for myself, the patient, and the assistant. There's a closer view of it. And then we've all got the masks that go there, so we're all basically hooked up. And we do wear a visor to protect our faces over and above the separate air supply. Here you're seeing me and my assistant with respirators. These are like the IABDM respirators. That is the patient under there. There's not much exposed, as you can see. So after the mercury is removed, the rubber dam is taken out. The patient's mouth is rinsed. All the draping is removed. All the dirty instruments are removed from the room. We do not reuse any bit of equipment. The instruments are sprayed with a special sulfur spray. The patient's face is washed with soap and water to remove the cream. And then the patient leaves the room after the rinse, which is post-op, which is 1 capsule of NaC mixed with vitamin C. And they just rinse with that and spit. The instruments as well as the room are decontaminated. And we set up an entirely new operatory setup. So it's 2 sets of equipment. We've got the first one that we use for the procedure, all the hand pieces, everything. It all goes out. And then it's all decontaminated. There's the combination that I use for the post-op rinse. And this is the mercury containment product that we spray with. It is horrible, the smell of it. It's just like having pure sulfur, but it does a great job. And we like to get the instruments decontaminated and wiped off before they're ever placed in the ultrasonic. Anything that releases heat, such as your ultrasonic or your autoclave, is going to release mercury vapor right into your sterilization area. Sorry, but that's the way it is. And then once everything's done, we give the patient 3 little sacklets of the Live-On vitamin C, because we do not have the facilities to do an intravenous vitamin C. So this is equivalent to a 25,000 milligram IVC. The next step, protection of the dentist. Here we are protecting the patient, worrying about them, but you've got your staff and yourself who are greatly at risk. We've got the exposure limits. The Oshapel is an 8-hour limit, 100 micrograms per meter cubed. The NIOSH, 8-hour limit, 50 micrograms per meter cubed. The NIOSH ceiling is 100 micrograms per meter cubed. And the American Conference of Governmental Industrial Hygiene, 25 micrograms per meter cubed in 8 hours. Okay, now we're into the facts of what kind of exposures we're actually getting. Okay, you just saw those, and it doesn't look very significant, but mercury vapor is absorbed through the skin at a rate of 880 to 2440 micrograms per centimeter cubed, with 27 to 43 minutes exposure. I mean, we're not going to do that much drilling time at removing mercury, but that is how much is absorbed. Blood levels show up at 216 to 844 micrograms. Sorry, I put the wrong letter down. The particles less than 10 micrograms can be inhaled during amalgam removal. In rat studies, the inhaled dust was immediately absorbed. The heart levels were 81 times the control within minutes. The brain and the liver 7 times control within 16 hours. Kidney levels rose slowly and remained high at 72 hours. Kidneys are the excretory organ. So procedural exposure levels. Opening an amalgam capsule, 400 to 1,000 micrograms. Chairside trap, who would have thought? 600 micrograms. And your normal rinses are not going to take that stuff down. They are just not. High-speed drilling, if it's dry, 1,200 to 4,000. IABDM had a really nice graph out years and years ago, but it showed a lot at these levels. High speed with water, that really reduces it down a fair bit. And then high speed water and suction, 15 to 40 micrograms. And polishing one of those wonderful amalgam fillings, like we used to do in the old days. Oh, they were beautiful, just so silvery and shiny. Just think of what we did to each other and ourselves. 500 to 900 micrograms. As far as respirators, they must be worn. This is NIOSH regulations and OSHA. If the ambient concentration of vapor exceeds the prescribed exposure limits, which you can see do. Dental offices are really profound violators of these rules. They've just gotten away with it. Workers should only use respirators that have been approved by NIOSH and MSHA. They also need to be ANSI certified, and those will probably, as the issues start coming, and I think over time they will start coming forward more, they're going to increase the regulations there as well. Don't use regular masks. They absorb your the moisture and that heat, and you get more mercury vapor released. So those wonderful white, blue, or pink masks, they're not going to do it. They just don't cut it. The particulate matter lodges in the filters, and because it's so small, it's the mercury vapor that's released from there, and then it's converted to methyl mercury, which is really toxic. So there's an example of a respirator that can be purchased at IABDM. They have the full face masks now too. That's what I was meaning about the coverage. The more we learn, the more we have to do. So we need to reduce the mercury vapor exposure in the operatory. So as I mentioned prior, vapor and particulates are the prime problems. The vapor's immediate, it's just immediately absorbed. The particulates, because of their size, they're absorbed through the skin, and then they become vapor. So they're one part and parcel of the same thing. So we do this with having a dental air vac. You've already seen that one, the big albatross, air filtration systems, and the negative ion generator. So Faust Company puts out a really nice air purifier. There are many more available. This particular unit does have a UV on it, which is nice for just keeping the bacterial load down in the office. Okay, OSHA does require that employees be given a written informed consent before the use of any toxic chemicals. Mercury is on that list of toxic chemicals. Women of childbearing age, they are not allowed to have an exposure more than 10% of the OSHA MAC, which is the threshold limit, maximal exposure. So that's not very much that they can have. They are pregnant. They should not have any mercury exposure. And NIOSH actually recommends annual medical monitoring, though the medical monitoring is not going to state a lot unless there's an acute exposure, because standard medical tests don't show it up. And any tests that we might do otherwise, such as porphyrins or anything like that, you know, NIOSH isn't going to know about it anyway or accept it. So we have to train the staff to be aware of the potential sources of the exposure. So that's amalgam scrap, vacuum system traps. That is one biggie. And the instruments. You need to decontaminate the instruments with Mercon spray prior to placing it into the ultrasonic or the autoclave. You've got to have proper toxic waste management practices for the contaminated drapes and disposables. On-site laundry, you need to have the dryer venting outside. You should have good biological support for the staff or encourage them to consume it. So we like to have good quality vitamins and minerals. I've got great compliance in my office with that. And everybody's, you know, we're all taking our vitamins, we're all taking our minerals, and they keep an eye on each other. And it's just because this initiates the blood chemistry changes. We encourage them to take magnesium between 400 and 600 milligrams a day. That's one of the minerals that mercury robs the body of. So we find we get a lot less muscle cramping and everything else in the employees if they do that. Vitamin B6 is another one. And then zinc. We just, vitamin C enhances the zinc excretion. So just because we like them to take a fair bit of vitamin C when they're at the office, we give them some zinc as well. And again, we encourage them to have eggs, broccoli, all the brassicas. Just basically getting down to some good nutrition. That's a choice they have to make. Some of them do it, some of them don't. So reducing mercury exposure in the environment. We've got the mercury separation and the mercury recycling. Okay, this is a water system mercury source estimate. This is confirming some of Michael's stuff from before. Dental offices, 41% of the water supply as compared to septic tank waste. Hospitals, 3%. So, stormwater. So the EPA, they do have their amalgam separator rule, and that's now again been delayed because there's a big fight with ADA and the EPA on the requirements. EPA does want 99% efficiency. ADA wants that reduced because they made some kind of arrangement prior, and they were allowing 95% efficiency. And there were actually some issues with the mercury separator companies that they were not removing the stuff. They did the testing themselves, and the removals were not quite as high as they stated on the percentages. So what the ADA wants to do is have a proposal that includes the provision that the older mercury separators will be grandfathered. So if they're only doing 95%, so they'd be in compliance for the life of the separator. And currently only 14 states are required to have separators. So there we've already talked about that. And they need to have the separators totally enclosed. You need to have a written recycling contract as proof of doing all this stuff. So actually this is one of the questionable amalgam separators as far as removal efficiency goes. It's put out by Solmatex. And for governmental compliance, you need copies of transportation receipts for the shipping of the filters to the facilities. You need a copy of the written contract with the recycling facility, and you need inspection sheets dated and signed to ensure the unit is working and that the filters have been changed. And for the mercury recycle, this is the age-old ADA, system salvage, store, and recycle. So wide mouth airtight container marked contact amalgam waste for recycling. Amalgam scrap should be kept underwater, as well as extracted teeth containing mercury. No chlorine line filters, and disposable chair side traps. Remember, those emit 600 micrograms. The filters on the amalgam separators, with the tact, it's once every 6 months, which sometimes is kind of strange because if you're not placing mercury, there's not a lot in there. But there's also an issue when you install these units, if they're hooked up to hygiene suctions. Hygiene tends to suction out a lot of toothpaste and their pumice, and they really mess them up. So you couldn't really get away for longer than 6 months. Okay? If you do find that they are filled, then you need to do it more frequently. But there is a guideline there. Okay, and the other systems have different ways they'll come in and actually take the whole unit. Some of them will be every 2 years. Yes? Yes, they do. Yeah. It is volume, but we tried that, and they actually started contacting us. You have not replaced your filter. We had a spare one anyway, but you know, they do actually keep track of those records. Just so you know there. Have you got the tact? The Solmatec. Yeah, and that one's one of the ones that fudged up their studies. Right. Isn't that great? But see, they were getting in just when a few states had made it directly mandatory, and then that's what happened. Right. He never changed it? Yeah, yeah. I had EPA come in a year after because they decided to do a tour of all the dental offices because that was mandated in 2012 in Maine. Yeah, so it's been quite a while. Or maybe actually it might have been, no, it was earlier than that. Yeah, that was a Solmatec. That's the one we're stuck with. There's lots of them. The IAOMT meeting always has some of the mercury. Yeah, yeah. So you can get them there. Otherwise, look them up, or IAOMT probably has a resource. I'm on vacation. But there are some good ones. And on the ADA, much as I dislike them, they do have some good resources and some charts on the mercury separators in their resource section. So I do recommend going there and checking that out. Oh. This is just a new addition to my office. And I was so annoyed about, I actually read some legal studies where or not legal, but they'd done inspections of dental offices, and I found out, it just hit me. I never ever thought of plaster traps or the amalgam traps. And then that was an area where a lot of offices were really non-compliant as far as the mercury vapor went. And then I found out that Mercon had actually put out this gel. This is a vacuum system line cleaner. You put it through once a month or once a week, and it releases the mercury vapor at the level of the traps, which makes me feel a little better. It's not cheap, $107 a bottle. It's a gallon. No. Thank heavens. But what price? Good health, right? It died. Computer died too. Oh, maybe that one? Oh, the batteries? Don't look at my bare feet. My feet hurt. You did? Whatever I... Is it? Enter would do it too? Okay, I'm ready on there. Just a couple more slides. Okay, we're almost at the end. Thank you for your patience. So the other thing you need to do is set up a relationship with a hazardous waste management company. There are many around. You just, again, you have to look them up. But you are required to get rid of your amalgam, and that comes at a cost. Your elemental mercury, your waste mercury, your fixer developers if you're still using the older X-ray units, medical wastes, your office wastes such as your fluorescent lamps and your computer peripherals. So, basic costs. For one room, you've got your negative ion generator, and that's the cost of the TACT. The HEPA UV filter, which is for the air. Your dental air vac, which is the albatross that sits on the patient's chest and sucks up every bit of gauze that you may lay adjacent to it. Your amalgam separator, which is $1,000 and up. It depends on the type of unit that you get. Respirators, you need at least 2. Your Rita meter or OPM, $850 to $1,995. So that runs you for a total of between $5,500 and 8,500. That's it.